Hello everybody, I'm back, this time with shock, hypovolemic, and cardiogenic. Let's talk first about really the definition of shock. What do all shock states have in common regardless of the type? And there's about 4 types that we're going to talk about collectively, and this group is hypovolemic and cardiogenic, as I said. So what do they all have in common? Well, all types of shock result in inadequate or decreased tissue perfusion. And really what that means is anytime you think of tissue perfusion, you think of oxygen delivery at the tissue or at the cellular level. And in shock, there is diminished or decreased tissue perfusion, not enough oxygen is delivered to the cells. And what happens when the cells do not have enough oxygen? Well, on the cellular level, remember from your patho that oxygen is needed for the cells to, well, survive, but survive because they can produce ATP. And ATP is the gas that keeps your cell working. And so without tissue oxygenation, the only thing the cell can do to make or produce ATP is move to anaerobic metabolism. That's what that means. The cell will produce ATP without oxygen. And that works kind of okay in that a little bit of ATP can be produced, but the problem is the byproduct that occurs because of anaerobic metabolism is a lot of lactic acid. And just by its name, you know that lactic acid, an acid, will drive the pH down, and so the body will become acidotic. And the fact that the cell is not able to produce enough ATP is bad enough, but the fact that the body pH is acidotic also causes to decrease the cell's ability to work, to do its job. And that will ultimately lead to the death of the cell and a lot of cells and ultimately the individual. So what is responsible for tissue perfusion? How is it that that oxygen molecule will jump off that nicely cradled hemoglobin or nice cradle of hemoglobin? And what happens is there must be an appropriate pushing force. In other words, like this picture here, that oxygen molecule must be kicked off. It's a driving force, and that driving force is the mean arterial pressure. And a mean arterial pressure of about 65, some books say 60, other books say 65, but really I think in your notes 70 is the better mean arterial pressure to have. And the individual has to have that minimum mean arterial pressure for that oxygen molecule to be pushed or kicked off the hemoglobin. And so therefore, if it's less than 65, then that hemoglobin will just cleave to the oxygen and it will just zoom right on by the cell. Now you know that the MAP, the mean arterial pressure, is usually on the monitor for you, so you don't have to calculate it. When you get a blood pressure even on a automated machine in the intensive care unit or just even on the med-surg units, you'll get the systolic, diastolic, and the mean arterial pressure. But of course, this is the critical care world, excuse me, and so therefore we have to calculate the MAP. And when you look at some blood pressures and you see these two that are here, 90 over 60 and 100 over 40, I want you to think about who is the sicker patient. In other words, who has the more diminished mean arterial pressure, meaning that their oxygen may not be sitting or landing in the cells. And so, of course, to figure out the MAP, we're going to have to do the formula. And the MAP is just a average of the cardiac cycle, the entire cardiac cycle. Now you know the cardiac cycle is diastole and systole, but diastole is mathematically 2 times longer than systole. That is why we have the equation systole plus diastole times 2. And then because you've got systole, diastole, diastole added together, you've got to divide by 3 because there's actually 3 parts to it. So when you look at the blood pressure 90 over 60, and we take 90 plus 60 plus 60, that equals 210. We divide that by 3, and that comes with a MAP for the 90 over 60, a MAP of 70. That's awesome. We want that. Excuse me. Now let's look at the patient with a blood pressure of 100/40. And when we do that mathematically to get the mean, we say 100 systolic plus 2 times the diastolic, that would be 80. 180 divided by 3 is equal to 60. So it's easy to see that any individual with a lowered diastolic pressure, because it counts for 2, is going to be dangerously closer to the minimum MAP, and so therefore they might not have enough perfusion. Because shock states don't just appear and magically call out to us, your patient's in shock, they are very subtle. And they're subtle because the body has a really strong mechanism of defense that can kind of hide what is truly happening. And so as a nurse, you're going to have to use a very systematic approach as you assess your patient and identify if your patient's in shock. And of course, the first step to that systematic approach would be to say, well, hey, is this patient even at risk for shock to begin with? And of course, because of all the things that we do, pretty much almost all of our patients are at risk. So let's do a system-by-system approach to assessment. And we're going to start at the top. I like to start at the top. You can start at the bottom, however you want to go, but I start neurologically. And in shock states, pretty much the first sign of a shocked state or an impending shocked state is an altered level of consciousness, and that's decreased level of consciousness. In other words, maybe your patient's not awake as they used to be. You have to always shake, 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 say, hey, what's going on? Or they might actually appear confused. I had a student who said to me, well, I'm assessing my patient and she's really not answering my questions right. She sometimes tells me the information accurately, and other times I said, well, how old is she? And she said, well, she's 45. And I said, well, that's not right, because unless you think she's having an acute stroke, it sounds like she's showing signs and symptoms of maybe some issues because she's got an altered mental status. So you've really got to have an index of suspicion because, of course, we constantly like to judge our patients a little bit and say, oh, well, they've been taking a lot of narcotics for pain, so that must be what it is, or they're just being goofy. So again, it's subtle sometimes, and you're going to have to really investigate. Another symptom is dilated pupils, and of course this is because the sympathetic nervous system in early shock states becomes activated, and sympathetic nervous system will dilate pupils. And if you think about it, sympathetic nervous system is that fight or flight, and so what do we need to be able to run from that saber-toothed tiger that's chasing us because we're scared? And that's dilated pupils, because we need to see really well. And then in cardiovascular, some of the things that are going to be early signs and noticeable is an increased heart rate. And again, that's because of the sympathetic nervous system activation. The patient may be diaphoretic, but they're not going to be diaphoretic all over. They're likely going to be diaphoretic like on their head, on their forehead, and maybe on their chest, but their hands and feet are going to be cool. And of course, you know that when the sympathetic nervous system is activated and there's vasoconstriction, it's going to shove or push blood from the periphery into the core. And so that's why you'll see your hands and feet, whereas the diaphoresis is because, again, that activation of the sympathetic nervous system. The pedal pulses are going to be diminished. Again, that's because of the vasoconstriction in the periphery, and especially way, way, way down in our feet. And then the prolonged cap refill. Now, you guys learned, I can never remember. I know it's either 2 seconds or 3 seconds for prolonged cap refill. Don't sweat the differences. You're not going to be asked, is it 2 or is it 3? It's basically going to say, is it prolonged or is it prompt? And then you've got narrowed pulse pressure is another sign of shock states, impending shock state. And what that means is that the systolic mathematically is very close to the diastolic. There's not much of a difference between the two numbers, whereas when it was widening, for instance, when you had your Cushing's trad, well, that top systolic number became higher, like in the 180s, and then your diastolic was way down in the 60s. So you can see mathematically when you subtract 110 to 88, there's not much of a mathematical difference. On the respiratory status, you're going to have an increased rate and depth, and this is because very early the patient will go into anaerobic metabolism, and so they're producing lactic acid, and you know that the respiratory system is going to compensate for metabolic acidosis and cause the respirations to be rapid and deep. They're going to blow off CO2 so that they can try and bring that pH back up. And also because your cells are not getting enough oxygen. Now, we really talk a lot about CO2 when we talk about breathing off, but you do know when you breathe in, you're going to breathe in oxygen. And so the cells are diminished O2, and therefore it's especially the cells in the brain. And so it sends a message to the respiratory centers in the brain that, yo, we're not getting enough oxygen here. You need to like bring some more in. And so the respiratory centers will tell the diaphragm, you need to speed up your respiration. So it's really a twofold effect of why the respiratory rate is rapid and deep. And of course, if you looked at blood gases, truly an respiratory alkalosis would give, with a low oxygenation, with the hypoxemia, would kind of give you a clue that something's going on that you really need to look into. GI and the gastrointestinal hypoactive bowel sounds, because of course we're not going to rest and digest. We've got the activation of the sympathetic nervous system, so we're going to run, and so your bowel sounds quiet down, and therefore with decreased bowel sounds you're going to have decreased gastric motility, and with that, if they're on a tube feed, then they may have an increased residual because it's not going to go in and down and then out. Genitourinary, you're going to expect to see decreased urine output because, again, as soon as the cardiac output goes down, which is what will happen initially in shock states, then that means that the kidneys are perfusing or have less perfusion, and you know the kidneys are the first organ to whine, and as soon as they have a decreased perfusion, then they activate the RAS and the sympathetic nervous system, but the urine output will decrease because of the decreased glomerular filtration rate. Now, the normal urine output should be 0.5 to 1 mils per kg. So in an 80 kilogram individual, they should have no less than 40 mils per hour. And Dr. Reed loves urine. Loves urine. Are you hearing me? So this is very important that you know this. Now, I've talked about some general signs and symptoms, or the fancy term clinical manifestations of an individual that might be in a shock state, but know that these shock states are divided into 3 stages: early, and then something else and something else. I can't remember the proper terms: early, middle, late. And so I have listed these specific shocks stages as well as the signs and symptoms in each of the stage. And it's just too goofy and messy to try and deal with all of those in this presentation. You really do need to just kind of look at it and kind of get a sense of what each stage represents as far as your patient's signs and symptoms. I put it in that shock worksheet, so it's there for you, as well as what you can expect on the vital signs. I do want to point out, and I've made a text box for it, you know, other than making a banner, I'm trying to let you make sure you realize that most of us think of shock as, when we were early learners, we thought of shock as low blood pressure, and that is not the case. That is not the definition of shock, because the blood pressure doesn't go down until the middle stage of shock. And the reason for that is because all of these compensatory mechanisms are present, and it winds up making or maintaining a minimum blood pressure, and that's what fools us. Now let's talk about a patient scenario so that we can guess what shock state this is. Now you know that I'm talking about hypovolemic and cardiogenic, so you can always guess, and you've got a 50-50 shot at being right, but really try and evaluate the pulmonary artery measurements, the hemodynamic measurements, and try and determine on your own, so stop the recording, what this shock state might be and why it is what it is, what I say it is. So you can course, debate with me. So here's our measurements. There's the hemodynamic measurements in front of you. And the first two questions I ask is, what would the nurse expect? In other words, what kind of shock state do you think this is? And what might be some causes for that shock state that you've identified? So let's look at the numbers, and of course I always say to you, look at the values that tell you about volume. I say CVP and you say right atrial pressure. The right atrial pressure is 1. And normal value for right atrial pressure, or CVP, is 2 to 8. Again, this is the time where you've got to memorize these numbers. Don't bring your green card into the testing center. You've got to have these numbers memorized. The CVP, or the volume on the right side, is low. The volume on the right side is low. When we look at the pulmonary artery pressure, we don't care about the pulmonary artery systolic. We do care about the pulmonary artery diastolic, and it is 2. Normal is between 4 and 12, so the pressure is low. That means the volume is low. The volume on the left side is low. Now, I could have also listed, if I wanted to, instead of the PAP, which has the PAD value, the pulmonary artery diastolic value, I could have just listed pulmonary artery wedge pressure. I could have said it was the same amount. It could have been 2, it could have been 3. Either way, one is 4 to 12. I think they're both 4 to 12 or close to that. It's close enough for us to know. Either way, the volume on the left side is low. Then when we look at the cardiac index, we see, well, you know what? It's 1.8. So the cardiac output that is adjusted for a body surface area, the cardiac index, is low. And the reason why the cardiac index is low is because there's low volume. In other words, if there's low volume in the body, if there isn't much volume in the body, then there can hardly be a whole lot of volume going out of the heart, because not a whole lot's going to return, and therefore not a whole lot is going to go out. The heart is going to pump what it has available to it, but if the preload is down, if the volume is down, then the cardiac output is going to be down simply because there's low volume. When you look at the systemic vascular resistance, it's elevated. Normal is 800, 1200. In this patient scenario, we have 2000. So the SVR is increased, and that gives you an indication that the blood vessel, the arterial bed, is vasoconstricted. And we know that is a mechanism of compensation, because vasoconstriction occurs as a result of the RAS system, and it is a matter of pushing things from the periphery into the core. So this is a means of compensation. And then the heart rate is 110. And again, we know this is a means of compensation because the sympathetic nervous system has been activated because of the low cardiac output, and therefore the heart rate is going to go up. So what should the nurse suspect? Well, I think it's pretty easy to see that this is most likely hypovolemic shock, because there is low volume, hypo, low. Now, what could the causes be? Well, the most obvious one that we automatically think about is blood loss. If it's a trauma history, then you know, okay, blood loss. But know also that there can be fluid loss, just plain pure fluid loss from an individual that has a lot of vomiting and diarrhea. It could also be a cause of third spacing, and what that means is there's a movement of water from the vascular space into the cells. So let's say in an individual who has ascites, well, what happens, or what has caused ascites, is there's been low protein in the blood because they probably have liver disease, and that has caused the water not to stay in the vascular space, and then to move into the tissue. And of course, burns will also cause third spacing. We're not going to talk about that too much in detail. We will when we get to burns. What would you identify as the hallmark characteristics of a patient in hypovolemic shock? Well, I think that's pretty obvious. We can see that the CI, or the cardiac output, and the CVP, right atrial pressure, the PAD or the PAWP are low. Their values are all less than normal. And so that is an indicator that this is hypovolemic shock. Now, I did list cardiac index as being low, and that's not really an indicator in and of itself of hypovolemic shock, but in the presence of a low CVP and a low volume on the left side, when the CI is low, then you know for a fact, well, whole body volume is low and the CI is low, so the whole body tank is low. What's the treatment? Well, I've always been saying, if the tank is empty, then fill it. So volume must be given first. So fill up the tank with what kind of fluid? Well, sometimes in some manner, it does depend on what the scenario is. But you know, the usual suspects for volume fillers are ringers lactated or lactated ringers, whichever way you want to say it. Normal saline is always a popular choice. And then if it's a trauma patient, then you do want to give blood, because normal saline, though it will fill the volume, the vascular space, it doesn't carry oxygen. So if the patient has lost a lot of blood, well, then they need that oxygen carrying capacity returned to them, and so therefore blood products are better. And then of course there's albumin, which I mentioned in the cardiovascular surgery as sometimes being given, and of course in a lot of patients that have liver disease, because they're not making albumin, then they're going to buy it and we're going to hang a bottle of it. The tank is full when the CVP, the PAD, and the PAWP are increased. In other words, you want to get the values back up to normal. If the CVP is now 3 or 4, well, you're getting there, but the tank isn't full. Just like if I said to you, go to Oklahoma, you wouldn't just put 1 or 2 gallons in your tank, you would fill it up. And it's the same thing with these scenarios. Fill up the tank, fill up the CVP to 8, and fill up the PAD, PAWP to 12. You would also expect when the volume has increased that the heart rate would go down, the systemic vascular resistance would return to normal, and then of course the urine output should improve. And again, this is why Dr. Reed loves urine output, because often before even the tank is completely full, the urine output will begin to increase, because kidneys are kind of like the windows into the soul, or the windows into the body, and they really do recover very quickly once volume is starting to be infused. And of course, if you had poor signs of perfusion, as in your cap refill was prolonged because you've got massive vasoconstriction in the periphery, then your signs of perfusion should improve also once that vasoconstriction is decreased. And again, notice that the PAWP, PAD, both of them tell you about the volume on the left. Now let's go back to the scenario from the beginning, and let's just pretend that you were a new graduate, and it's July 1 when all the new physicians that have just graduated from medical school are filling the teaching hospitals, and you take these hemodynamic measurements, and in this scenario, in this particular scenario, let's say your blood pressure was a little low, like 100/60, and so you call the physician and you report the hemodynamic measurements, and then you report what the vital signs are, and of course the physician with very little experience will go, oh my gosh, that's just terrible, the blood pressure is awful, you need to go ahead and hang a dopamine drip. What are your thoughts on this order? Well, hopefully you're going to say or know, first off, that dopamine is a vasoconstrictor. And before you give a vasoconstrictor, I said the tank must be full. First, we fill the tank. So you tell that first-year resident that you will be happy to give the dopamine, but not today. Maybe later, or maybe tomorrow after your vascular tank is full. So once your CVP gets up to 8 and your pulmonary artery diastolic is in the 12 range, and if your blood pressure at that point is still low, especially if your MAP is less than 65, well, then it's time to give the vasopressor. Then it's time to give dopamine. Because dopamine, the vasopressor, is going to press down, just like what it says, on the vascular space. And you cannot, or you should not, press down on the vascular space. It won't do any good if that vascular space is not full. So it is extremely important that you give the fluids first, fill up the tank, and then if the blood pressure is still low and it is needed, then the vasopressor can be given. Let's move on to the next scenario. And we've still got that pulmonary artery catheter, and our hemodynamic measurements are before your eyes. What should the nurse suspect? Which kind of shock state should the nurse expect? And what would be the causes of that shock state? Well, when we look at the values, we see that the CVP, the right atrial pressure is 15. The volume on the right is high. The value is 15. It is greater than 8. The pressure is high. Therefore, I know volume equals pressure. The volume is high. The volume on the right side is low. The PAP is 60 over 25. I'm concerned with the PAD, pulmonary artery diastolic, value of 25. Normal should be up to 12. The pressure is high, therefore I know the volume is high. The volume on the left side is high. Now when I look at the cardiac index, this is the tell-all. Knowing, without even looking at anything, if I said, you know what, this patient could have drunk 4 liters of fluid. They just drank 4 liters of fluid. It's summer, it's Texas, they're thirsty. So they drink 4 liters of fluid, and without looking at the value, you know that if you had a lot of fluid in the vascular space, your cardiac index should be normal. Might be high, but it should at least be normal because there's plenty of volume. And the heart does not have a choice in its job. It must pump whatever is delivered. And if the volume is high, then the cardiac output should be high also. In our scenario, the cardiac index is low. It's 1.8. And because the volume is adequate, it's more than adequate, it's high, that cardiac index that is low indicates the heart is not pumping. It is not pumping the volume that is being delivered to it. Therefore, the heart has a contractility issue. So if the cardiac index is low, but the volume is low, well, that makes sense. There's no volume to circulate around. The index is going to be low. But if the volume is high and the cardiac index is low, then the heart is not doing its job. It is not pumping the volume that is presenting itself. When we look further, we see the systemic vascular resistance, the SVR of 2000, that is high. And we know that is a sympathetic nervous system response. It doesn't matter how much volume is in the body. If the cardiac output, the amount of blood that is being delivered to the cells in the body, especially, you know, that rascal kidney, if there is not enough volume being delivered, the kidneys are going to go, yo, where's the blood here? I need to filter. Where's my blood? And therefore, they're going to do RAS, and you're going to have angiotensin, you're going to have vasoconstriction, and then you're going to have aldosterone released, and we're going to hold on to sodium and even more water. So all of this escalated or elevated SVR is a result of vasoconstriction because of the from compensation for the decreased cardiac output. Heart rate of 110, again, you know, is sympathetic nervous system activation because of the decreased cardiac output. What should the nurse suspect? Well, again, your odds are in favor of cardiogenic shock because we already used hypovolemic. The only one left is cardiogenic. But hopefully you see why this is cardiogenic. Usually ischemic is the cause. In other words, the individual has a myocardial infarction like we did in our heart failure scenario. Our patient subject had a myocardial infarction, wiped out a good portion of the cardiac muscle, and therefore there was less pumping power. Less pumping power means that these individuals can go into cardiogenic shock. But notice that long-standing hypertension, in other words, constantly the left ventricle pushing against that high pressure in the aorta will cause the left ventricle to weaken just in and of itself. It doesn't happen in a day, a year, or a month or a year. It happens over a few years, and of course it's untreated hypertension. Now, what would you say would be the hallmark characteristic and the treatment for cardiogenic shock? Well, cardiogenic shock characteristics are going to be that your volume values are going to be high. So your pulmonary artery diastolic and pulmonary artery wedge pressure, the volumes that represent the left side of the heart, are going to be elevated. And then your right atrial pressure, or CVP, that is the volume on the right, is going to be elevated also. But here's where there's a difference. The cardiac output is, in spite of all that volume, the cardiac output is also going to be low because the heart is not effectively pumping. What is the treatment? Again, this is pretty much a repeat of what we've already learned, but hey, this will help you remember it. We'll just keep saying it over and over. If the tank is empty, fill it. If the tank is full, empty it. We need to get rid of all that excess volume so that we can help the heart out, help the pump not have to work so hard. And how do we get rid of that excess volume? With diuretics. And then the contractility. And again, you're not going to give a diuretic and then wait for 8 hours, 10 hours, or whatever until your patient either urinates or dies. We're going to give a contractility drug pretty soon. Of course, you're not going to have to know, you're not going to be asked, well, what time frame would you give the difference? No, they're just going to be individual scenarios. You just need to recognize that when your volume is high and the index is not high, then you've got a pump problem. And so with decreased contractility, we need to give a pump that will increase or improve the pump or the contractility. And those drugs are all called positive inotropes. Digoxin is less likely to be given in an acute scenario, but dopamine, dobutamine, epinephrine, and milrinone are very common positive inotropes. For the increased systemic vascular resistance, that represents an extreme increase in the workload of the left ventricle. That left ventricle is not doing so great. It is failing. So we really need to make things easier for it. We really want it to bicycle downhill instead of trying to pump uphill. And so we're going to use vasodilators to reduce the workload of the ventricle. And those vasodilators are nitroglycerin, nipride, and nicardipine or cardine. And that nicardipine, again, is a calcium channel blocker. What about the heart rate? The heart rate's increased, and really, if we give a positive inotrope, and we do increase the contractility and the cardiac index goes up, then by all rights and purposes, the heart rate should go down. The problem is dopamine and dobutamine and epinephrine for sure, can increase or elevate the heart rate. So sometimes we give a beta blocker so that we can decrease the heart rate so it won't be so responsive, won't be so rapid, because again, a rapid heart rate represents a lot of work for this failing heart. If you have any questions, be sure and email me. I hope this makes sense.